हाँ
कैमरा ऑन करना।
गुड आफ्टरनून।
Congratulations.
फॉर व्हाट?
वन और क्वेश्चन था।
ओके
We can introduce.
हाँ वॉइस का तो खोल लेंगे अपने आप ही। वॉइस का
हाँ गो टू मीटिंग में
हाँ
हाँ वो खुल जाएगा।
रिस्ट्रिक्टेड हॉलीडे कितना मिलता है? कुछ आइडिया?
दो
हाँ,
दो
1 साल में।
कब लेके आए हैं?
फरवरी में अभी जून में।
चलो मैं भी जाती हूँ फिर, है ना? Anything you would need?
खुल रहा है ना, एक बार देख लीजिए।
हाँ ये कौन सा है? Yes, ma'am. Yes, ma'am.
Yeah, okay. You're waiting for the students.
Yeah, ma'am.
to
It's only
join. Because I think
106.
some of them are confused whether there's audio or not. Okay, just wait till everyone joins.
Okay, ma'am.
Thank you.
Good afternoon, everyone. Now it's already 7 minutes past 2, so I think I should be starting. Okay. So today we are doing the elbow and the wrist joint. Yeah, very good afternoon, Mahesh, and everyone. Okay, so we're starting with the elbow joint first, then we will go to the wrist joint. Now these are the learning objectives which we'll be dealing one by one. So let's see what are the bones that form the elbow joint. So I think everybody would be able to recognize these bones. This is humerus, this is the anterior view, this is the posterior view. Can anyone tell to which side does it belong? This humerus? Right side. Okay, why do you say so? What are the features that you look?
Medial condyle is more prominent than the lateral. The head is towards medial.
Okay, so you look for the 6 points, na? This anterior, posterior, medial, lateral, and superior and inferior points. Distinguishing features which help you to determine the side of the bone. So this is the radius, this is ulna, and here we are in the humerus, we are concerned about the lower end of the humerus, this part, and the forearm bones, that is the radius and the upper part, which will articulate to form the elbow joint. Here you can see in this picture the articulation between the lower end of the humerus and the upper end of the ulna and the radius. This is the anterior view and this is the posterior view. So anteriorly you can see, what are the things which you in the lower end of the humerus you are able. This is the medial epicondyle, the lateral epicondyle. These are the two fossas. This is the coronoid fossa, this is the radial fossa. These are the off-white colored, they are the articulating surfaces. Okay, and in the lower end or the prodistal end, you can see the coronoid process of the ulna, shelf-like projection, the tuberosity over here, the ulnar tuberosity. On radius, you can see the head of the head, the neck, the radial tuberosity, and some part of the shaft of the radius. And the posterior aspect, from the posterior aspect, again epicondyle, the lateral epicondyle. Now this is the olecranon, okay, the superior surface of the olecranon, the subcutaneous part of the olecranon. Then a small, on the medial aspect, you can see a small part of its self-like projection, that is the coronoid process, the head, that and the neck, and the shaft of the both the radius and the ulna. So what first we should know, what are the bones that articulate to form the elbow joint, which you have seen. Now how do you classify the joint? So it is a hinge joint of complex variety. It is a complex hinge joint of synovial variety. Okay, so if you are talking about the joint, let's see the articulating surfaces. So this part which is at the present at the lower end of the humerus, this is known as the, what do you call this? You have already done the features of the lower end of the humerus. So what is this? The trochlea. The trochlea. And what is this?
Capitulum.
The capitulum. The capitulum. So what is this trochlea? Is, you can see it is divided into, there is a depression over here, isn't it? So a medial part and a lateral part, and also this part, this medial edge. Okay, this medial edge is known as the medial flange, and this one the lateral flange. So when you compare these two, you can see that this is much extending distally. It is about 6 mm below the lateral flange. Okay, and between the trochlea and the capitulum, again there is a groove over here. Can you appreciate the groove? And then you have the capitulum, the rounded part. Now this you have, and here you cannot see the actually the olecranon and the trochlear notch, because it is articulating with this trochlea of the lower end of the humerus. But here you can see the head of the radius, but this does not, it actually articulates with the ulna, forming a superior radio-ulnar joint. But during movements, this head of the ulna, especially during the flexion, it comes in contact with the capitulum of the lower end of the, which is present in the lower end of the humerus. Now let's see the once again. So this is just the individual bones and the lower end. So here's the trochlea, the capitulum. The trochlea and the capitulum, you can see there is a elevation present between these two, which divides these two surfaces. The trochlea, it is like a pulley. Okay, it is like a pulley, and this capitulum is rounded just like a head. Hence, it is known as the capitulum. Just above the trochlea, you can see a depression, which is the coronoid fossa, and just above the capitulum you can see the another fossa, which is not, it is a little bit shallower than the coronoid fossa, and it is the radial fossa. Now coming to the posterior aspect. Posterior aspect, there is a single depression or on the bone, which is known as the olecranon fossa. And also you can see the trochlea extending into the posterior aspect. This part is again extending into the posterior aspect. And also in the lower end of the humerus, you can see a groove for the, you can appreciate the groove for the ulnar nerve. Now this is the, from the inferior aspect, you can make out the trochlea. There is a depression between the trochlea and the capitulum, so it separates these two surfaces. And also you can see the medial flange is more 6 millimeter below the lateral one. You can, okay. Now coming to the superior aspect of the, this is of the ulna and the radius. Now here you can, in the individual bone, you can clearly make out the trochlear notch. The trochlear notch is present on the anterior surface of the olecranon and the superior surface of the coronoid process. In between these two, there is an intervening part of the bone which is actually not non-articular part, the non-articular part of the joint. This olecranon, you can see the anterior surface, this is articulating. It is divided, this part is divided in two parts, the medial and a lateral part. Okay, and here also you can see there is an elevation over here which is dividing the trochlear notch, which is present on the superior surface of the coronoid process, into medial and a lateral part. Here you can see the proximal radioulnar joint, the head of the radius, and the depression or the articular fovea which is present on the superior surface of the head, which actually comes in contact with the capitulum of the condyle of the humerus, which forms the condyle of the humerus. Okay. Now you have already seen the joints, the bones forming the articular surfaces, and you have seen that it has got two parts, the humero-ulnar part and humero-radial parts. Okay, so the humero-ulnar, as the name suggests, it is the articulation between the trochlea of the humerus and the trochlear notch of the ulna. And the trochlea also resembles a pulley and is divided into a medial and lateral flange by a spiral groove, and that the medial edge is about 6 mm below the lateral edge. The trochlear notch having articular surfaces present in the olecranon and coronoid processes, and the humero-radial articulation, that is the articulation between the capitulum of the humerus and the head of the radius. So this joint is a very stable joint, and it is fully congruent when the forearm is midway between the pronation and supination when flexed at right angles. That is okay. Now here you can see the lateral view and medial view. First the medial view, we can see the trochlea. This is the trochlea of the humerus, which is fitting into the trochlear notch formed by the olecranon and the coronoid process. Okay. This is the lateral view. In the lateral view you can see this is the flexion, this is the flex position. So here during flexion, the capitulum of the humerus actually fits into that depression which you have already seen on the superior surface of the head of the radius. Okay. And from now coming to the capsule of the joint. When you are talking of the capsule, so this capsule will hold the joint in position. Okay, it will, the articulating surfaces, the edges of the articulating surfaces, they are actually within the capsule. They are covered by the edges are covered by the capsule, included in the capsule. So this red mark which you are seeing over here is the capsule of the attachment of the capsule of the elbow joint. So let's see, this is the capitulum, this is the trochlea. So you start the condyles, the epicondyles are not included in the capsule. Okay, they are not included in the capsule. So we start, when you draw, this is very important for you to draw the capsule during the exam. We do ask about what is the attachment of the capsule of the elbow joint or whichever joint you are being asked. You should know the capsular attachment of that joint, which is very important. So starting from the lateral edge of this capitulum, excluding the lateral epicondyle, we go upwards. The radial fossa, the edge, it will go along the superior edge or margins of the radial fossa, then medially continuing above the coronoid fossa, then this is the lateral margin of the trochlea excluding the medial epicondyle along that. Okay, this is from the front, this is an anterior view. Okay, and the lower end you can see again the articular edges of the articular surfaces, the capsular attachment, and then over here you will have, there is a annular ligament. Here you can see the annular ligament which surrounds the head of the radius, which is attached to the anterior and the posterior margins of the radial notch, which is present on the lateral aspect of the coronoid process. So this capsule actually goes and blends with this annular ligament. On posterior aspect, again this is the part of the olecranon fossa. So we'll go along the edges of the olecranon fossa. Okay, it will go like this on the humerus, and then down here it gets, again this is, here you get the annular ligament, it gets blended with the annular ligament, and it is still here you can see, but on this, okay, there is a part of the coronoid process, again the edges, and over here I did not mark it because it becomes so this whole thing is the attachment of the capsule of the elbow joint. Now besides the capsule there are certain ligaments. These ligaments actually they are the thickening of the capsule of the elbow joint. Wherever you get the ligaments, they are actually the thickenings present in the capsule of the elbow joint. So here you are getting the one, this is the medial aspect where you get the ulnar collateral ligament, and this is the radial aspect or the lateral aspect where you will find the radial collateral ligament. So let's see the ulnar collateral ligament which strengthens this capsule of the elbow joint. So you have got three bands you can see over here. It is in triangular shape. The apex is attached to the medial epicondyle. Okay, the apex is attached to the medial epicondyle. And when you look the anterior band, it goes to there is a tubercle present on the medial edge of this tuberosity. Over here there is a small tubercle, ulnar tubercle, which is present. So this anterior band goes from the medial epicondyle to this tubercle. Then there is a posterior band. This again from the medial epicondyle to this part. Here it is more appreciable, to the medial edge of this tuberosity, ulnar tuberosity. And in between, connecting these two, the anterior band and the posterior band, is an inferior band over here, which goes all along this margin, the olecranon and the olecranon and the coronoid. Along the medial margin of this olecranon and olecranon, actually it is not that visible over here, only you can make out the anterior and posterior band. So these will connect, this ulnar collateral ligament, which is present on the ulnar side or the medial side. It is triangular in shape, having an anterior and posterior band connected with an inferior band. So when it is attached to which is present on the lateral side of the olecranon, there is a small gap. It converts this. There is a small gap in between. So this through this small gap, the intracapsular pad of fat is actually continuous with the extracapsular pad of fat. So there is a gap between this part here. between the this inferior band. Now coming to the radial side, where you get the radial collateral ligament. So the radial collateral ligament extends from the lateral epicondyle to the, and it down distally it gets merged with the annular ligament, which is around the head of the radius. So there are along with the capsule of the joint, you have two ligaments, that is the ulnar collateral ligament and the radial collateral ligament for the strengthening of the joint. Now again I have made this just individual bones. You can see along the lateral edge of this capitulum, then the proximal edge of the radial fossa, and then continuing into the proximal edge of the coronoid fossa, along the medial margin of the coronoid fossa and along the medial flange of the trochlea, and posteriorly it will continue along this line. So along this olecranon fossa it is continuing and then up to here. Now on the ulna, it is marked around the edges of the articular surfaces, okay, and then it continues, where here you will get that ligament. Which ligament would be present over here? On the medial side of the capsule of the joint? The ulnar collateral, yeah, it is medial side, so it is the ulnar collateral, and on radial side it would be the radial collateral or the lateral side. Okay, so this capsule actually blends the ulnar ligament also. They are all blended over here. So it will continue along the margins, and then over here it gets merged under the annular ligament of the present on the head of the radius. Now this is since a synovial joint, so the capsule is underlined by a synovial membrane. So here you can see that only this synovial membrane, which is along this part, and some part of the synovial membrane you can see that it is going extending beyond the annular ligament. So this is the attachment of the capsular ligament, the synovial membrane along the capsule is lined by the synovial membrane. Okay. Now here I would like to, I just forgot. So these parts, this fossa, the coronoid fossa and the radial fossa and the olecranon fossa, at this part there is an extra capsular pad of fat. Okay, there is extra capsular pad of fat. So during these extra capsular, that means extra synovial, extra capsular. Okay, so I just go. So actually I don't have, I did not put the picture of that. So there is a pad of fat, extra synovial pad of fat, which is present over in the olecranon fossa, the coronoid fossa and the radial fossa. So when during flexion, when you flex, this pad of fat goes inside flexion and extension. These pad of fats goes inside these fossa. They are lodged by the these fossas are covered by that extra synovial pad of fat. Okay. So during flexion, this olecranon fossa, by the triceps muscle, push that extra synovial pad of fat into this fossa, and during extension the brachialis would actually put these pad of fat inside this fossa. Now coming to the intracapsular but extrasynovial. Yes, yeah. That was a slip of tongue. Okay. Now coming to the structures that are related to the joint. Okay. So now since you have done the muscles and the nerves and the vessels around of the arm and the forearm, you should yourself be able to tell what are the structures that are related to the joint. For example, muscles. If I show you just the pictures, okay, just look into this picture. Okay, I will go better picture. Okay, now tell me from this picture, what would be the muscles that would be related anteriorly to this joint?
Brachialis.
The brachialis. Wow. Okay. The biceps. The biceps. Biceps, the brachialis. Okay. Posteriorly, what are the muscles that would be related to this joint? Anconius, yes, the anconius is going inserting over here. Then the triceps, which goes to the posterior aspect of the this olecranon, superior surface of the olecranon. Okay, and what would be the nerve that is related to this joint? The radial nerve. Okay, the radial nerve anteriorly, and the ulnar nerve. Okay, the ulnar nerve, the radial nerve. Radial nerve, you can see it in the anterior aspect. If you remember the video I had shown you, which is within the cover of the which muscle? Hello?
Brachioradialis.
Brachioradialis. When you retract the brachioradialis, you could see the stump of the or the main trunk of the radial nerve. So it comes into the anterior compartment by piercing the lateral intermuscular septum, isn't it? And this ulnar nerve, it is actually, ulnar nerve comes from which cord? Which?
Posterior.
Posterior cord. And radial nerve comes from which cord?
Medial.
Medial nerve. Medial cord. Medial cord. No, no, no. The radial also comes from the posterior cord. The posterior cord. Ulnar comes from the medial cord. Yes. Good.
One at a time, please. All of you, when you speak simultaneously, nothing is audible. One at a time.
Okay. And the arteries, only one artery is over there in the arm, that is the brachial artery and its branches. What are the branches of the brachial artery? The radial and the ulnar artery. Okay. There are certain other nerves which here you can see the ulnar nerve, the median nerve, the musculocutaneous nerve. So what is Hilton's law? Can anyone tell me?
The skin and find is supplied by the same nerve which supplies the muscle and
muscle and?
The nerve which supplies to muscle, that only will supply the point and the skin nearby.
Which? The nerve which supplies the muscle? Hilton's law. I'm talking.
Supply the point and skin.
Joint and skin. Okay.
Muscle. You didn't specify what muscle, not any random muscle. The muscle has to be a muscle which is acting on the joint. So the nerve which supplies any muscle acting on the joint will also send an articular branch to the joint and the skin overlying it. That's your Hilton's law. So therefore, the nerve supply of all the muscles acting on a particular joint also goes to the skin overlying the joint, both surfaces, all surfaces, as well as to the joint itself on which those muscles are acting.
Okay, before going to the movements and the muscles, there is one more thing I would like to stress upon, that there are certain bursas which are related to the joint. Okay, so there is on posterior aspect you have got this olecranon bursa just in front of the triceps muscle. Okay, and also there is a subcutaneous bursa over this subcutaneous part of the posterior surface of the olecranon. Now coming to the movements and the muscles they are producing it. So you already know what would be the movements at this, only flexion and extension, but there is a slight abduction and adduction of the ulna. Why? Because this ulna is actually making a angle with the long axis of the humerus, that is about 165 to 170, because I am giving you some range, because some book says 165 and some 170. So the long axis of the humerus and long axis of the ulna, they are not in a same line. So this ulna, the long axis of the ulna makes a angle with the long axis of the humerus, that is 165 degrees, and which is known as the carrying angle. And if you see, when you are lifting a heavy weight, okay, when you are lifting a heavy weight, suppose you are someone is holding a bucket full of water, you can see this carrying angle is actually increased. Okay.
Ma'am, we were told that the carrying angle is about 15 degrees.
15 degrees. Okay, there is some difference in this, because the newer grace says that. Okay.
Okay, ma'am. Ma'am, so
Because
we have to now learn 165.
No, see, just a minute. I'll tell you, I'll clarify this. Okay. So there is the long axis of the humerus, and there's a long axis of, the long axis of the arm, and there's a long axis of the forearm. So one angle you can define, which is the acute angle between the long axis of the arm and the forearm. So some books describe that as the carrying angle, in which case males will have a greater value for the carrying angle, almost 170 degrees, and the females will have a few degrees less than that, say 165 to 167. Okay, the acute angle. Or you can define it as the angle by which the long axis of the forearm deviates from the long axis of the arm. So that angle is about 15 degrees. You understand? If you stretch the long axis of the arm downwards, the long axis of the forearm deviates by about 15 to 20 degrees from the long axis of the arm. Have you understood it? So the values would be the same, isn't it?
Yes,
Is this
ma'am.
so? Okay.
Thank you.
So 165 degree is also correct. Please proceed, Dr.
Yeah, ma'am. So this flexion, the muscles which produce flexion, that would be brachialis, biceps and brachioradialis, and extension, the triceps and coneus, and also by the gravity. So when you read about the muscles, each and every muscle, when you are dealing with individual muscles, so you would be able to know what are the muscles that produce flexion and extension at the joints, at the elbow joint. And also when you read the insertion or the distal attachment, so you would be knowing how the movements are caused. These movements are caused in the at that joint. Okay. Now anastomosis around the joint. Now this is the anastomosis. There is another anastomosis which we have already done during the scapular anastomosis. So can anyone tell me what is the anastomosis means what? What do you mean by anastomosis?
Two different branches of arteries meet.
Two different branches of, okay, there is, yeah. So you,
branching network of anatomy.
yeah, so the main artery, there would be a main artery giving off branches, okay.
Connection between diverging branches of arteries or veins.
Yeah, you can call it. So so there would be a, yes ma'am.
What is the scientific definition of an anastomosis? scientific definition. Now somebody has indicated it in the text box. A pre-capillary or a post-capillary communication between blood vessels. It can be between an artery and an artery, an artery and a vein, or a vein and a vein. That's an anastomosis. So this definition was told to you. So now come to the medical mode from the layman mode. Your medical students now be technical, be scientific in the way you describe things. Please continue.
Okay. Now here this is the anterior view of the elbow joint, and this is the posterior view. So on the anterior view, this you can see one artery, that is the brachial artery, which dividing into the radial and the ulnar artery, and this radial and the ulnar artery, again they are giving off branches which will actually anastomose with the branches which are given off by this brachial artery and the other branches of the brachial artery. Okay. So on the, let's see what are the branches. So the brachial artery is dividing into a radial and the ulnar. The ulnar is giving on the medial aspect, it is giving off recurrent artery, anterior and a posterior recurrent artery. Anterior because this goes anterior to the medial epicondyle, and posterior because it goes to the posterior. And since it's coming from ulnar, it is named as ulnar. Recurrent because it is tracing back. Similarly, you have the radial artery. From this, the radial recurrent artery is going out in front of the lateral epicondyle, and then from the brachial artery on the medial aspect, there is a superior ulnar collateral artery and the inferior ulnar collateral artery, which will actually anastomose. There would be between with the anterior and posterior ulnar recurrent arteries. And on the radial side, this radial recurrent artery will anastomose with the radial collateral artery, which is coming from the profunda brachii artery, which is a branch from the brachial artery. So where would you find this profunda brachii artery? Because the brachial artery is over here. Where would be the profunda brachii artery? In the radial groove, posterior, on the posterior aspect. That's why you can see this radial collateral artery piercing this lateral intermuscular septum. Okay. And on the posterior aspect, this is the posterior aspect, but here it cannot see the okay. So here you can see the inferior ulnar. It is very small, you cannot make it, but the inferior on the lateral aspect, this is the inferior ulnar collateral artery and the superior ulnar collateral artery. Actually in this diagram you can see the lighter red, the light shaded red, which shows that these are the on the posterior aspect, that is the middle collateral artery, the interosseous recurrent artery, and there is a, you can see the connection between these two, the inferior ulnar collateral and the middle collateral artery. So these are the anastomoses which are of the various blood vessels which are present around the elbow joint. So why do we have the anastomosis around here? So when you flex the elbow, okay, so when you flex the elbow, what happens? There is kinking of this. Okay, recurrent means what? It is actually, recurring means someone which reoccurs. Collateral means what do you say?
Collateral normally is the term is used to indicate something which was parallel along the lateral aspect in the same direction as a particular blood vessel or nerve. When a recurrent is one which goes in the opposite direction. That is the difference.
Okay.
Okay, ma'am, thank you.
So when you when there is a flexion of the elbow, there is a kinking of this brachial artery. So the blood flow would be sluggish over here. Okay, and sometimes it might get what blocked also. So these branches which are given off, which on the lateral aspects, lateral and medial aspects, they will supply the distal part of the forearm. It would be continued. So if it is blocked over here somewhere, or which this place, so there would be the flow of the blood flow would be sluggish. So it might be that the distal part of the forearm would not be getting enough blood. So all these branches, which are the anastomotic branches, through this part the blood flow would be continued. And sometimes it so happens that during some fracture the brachial artery is blocked, is hampered, damaged. Then also this maintains the blood flow to the distal part. Okay. Now coming to the applied aspect, this you have already done while doing the humerus, and so you have seen the supracondylar fracture, which is very common in children. All these applied aspects we are giving you right now, just you should know, because this will be dealt in a detailed manner later on when you go to the other semesters. So this supracondylar fracture is common in children, and it is seen when there is a fall on the outstretched hand. Here you can see this in this picture. The lower fragment moves posteriorly, whereas the upper fragment anteriorly. And when it moves anteriorly, as I told you, the brachial artery gets damaged, and if damaged in the sense, it will block the blood flow to the distal part, and the collateral circulation, the anastomosis might not be able to supply the distal part and forms ischemia. There is a condition, ischemia or ischemia, which is caused due to the poor blood supply to that area. Then there is a dislocation of, you can see find some cases, dislocation of the elbow joint, where this part, the olecranon, moves behind posteriorly, and the relationship of the humeral condyles and the olecranon gets disturbed. You have seen that the two epicondyles and the head of the olecranon, they form a triangle. So this is disturbed when there is a dislocation of the joint. Then there is a condition which is known as the tennis elbow.
This is typically very important, that in full flexion of the elbow, the triangle formed between the point of the olecranon and the two epicondyles. You can palpate it yourself in your own arm and forearm. Just feel the medial and lateral epicondyles and palpate the posterior edge of the olecranon process. It forms an equilateral triangle, whereas this is in full flexion. In full extension, the three lie in one straight line. So this is the relationship which clinicians examine in order to see whether the elbow is in its proper position or dislocated. So an orthopedic surgeon will look for this relationship, right? So in elbow dislocation, this will be obviously disturbed, right? Can you feel it, all of you? Anybody please respond? Can you palpate the olecranon in between the two epicondyles? You know, there's a space. Yeah, so you can feel it. You can feel that it's forming a triangle in full flexion, and when you extend your elbow, they come to lie in almost one horizontal line, right? Or one transverse line.
Yes.
Right. Please continue.
Okay. So there are condition when there is during playing tennis, there might be the partial tear of the radial collateral ligament on the radial side. Okay, and
this condition, Dr. Monica, assumed national importance at one time. Can somebody tell us who was that celebrity who got a tennis elbow? And it was front page national news. Yes, that's right. Riganka Bhaumik had the answer. Sachin Tendulkar, that's right. And it's not just the radial collateral, but also the common extensor origin
Yeah,
which is affected by the inflammation. That is inflamed in tennis elbow, because it's a tear of the radial collateral ligament, which is along with involvement of the common extensor origin, inflammation of the common extensor origin. Yeah, it's continuing.
Okay, ma'am.
It's not just tennis players, even cricketers can get it, or
Yeah.
other people as well, any athlete with weight plays.
And there is one other condition that is known as the golfer's elbow, where there is inflammation of the common flexor tendon, and this is due to the repetitive flexion and pronation at the elbow joint. So these conditions we are dealing in, just we are giving you just an overview. Detail will be you will be doing later on in the other semesters. Okay. So this is the end of the elbow joint, and I would like to tell one thing. Okay. So in this picture, can you see this? There are two different parts. There is an elevated ridge, okay, which is present over here, and you can see the medial part and a lateral part, which is and this olecranon, with beak-like projection, which fits into during extension, fits into this olecranon fossa. So during extension, what will happen? This medial part, okay, this medial part is actually comes in contact with the trochlea. This I have already told that this is divided in two parts by a spiral groove over here, medial and a lateral part. Similarly, here also you can see it is divided into two parts. During extension, you can yourself see that this medial part comes in contact with the trochlea, and during flexion, this lateral part comes in contact with the trochlea of the humerus. Okay. So in this lecture, you should know about the joint, that is what is the type of joint, the classification, the attachment of the capsule, what are the ligaments which strengthen this capsule, what are the relations of this, important relations of this joint. Okay. Now I am going to show you the video.
Dr. Monica, play
Yes.
all three, even the first one.
Okay.
There are 3 videos for it.
So this, which muscle is this, which has been retracted proximally?
Biceps brachialis.
That is the biceps brachialis. Okay. So between the, and what is this? What nerve or vessel is it?
The brachial artery.
Brachial artery. And this muscle?
Brachialis.
Yeah. Now you can see the joint is visible over here. This is the head of the radius. Okay. Okay, let it play. So this would be the annular ligament, the capsule of the elbow joint, and inside you can see the clearly. Can you see this trochlea, the capitulum, the depression between the capitulum and the trochlea?
Yes, ma'am.
The medial flange, the raised edge, and the this is the medial flange and the lateral flange. Here you can see the rim, the head of the radius, the depression, which actually during flexion comes in contact with the capitulum of the humerus. You can see now the during flexion you can make out. So once again I will play. So this is the biceps, you can see the two heads, the brachialis muscle, the joint. The capsule has been divided so that you can see we are seeing the inside of the joint. See, it is how it is glistening. Why? Because of the synovial fluid. So now everything has been removed, the surrounding structures, and just the joint is visible over here. Now how can you, since you are not seeing the whole limb, how can you identify by looking at this thing, this joint, as which is medial, which is lateral? So you can see the medial epicondyle here over here, which is more prominent, and also you can make out the head of the radius over here. So this is the medial and this is the lateral part. Here you can see the attachment of the capsule. Okay, the attachment of the capsule. I told you on it includes this articular edges of the articular surfaces. The capsule is lined. It is lined by the capsule. The capsule is attached over there. Again, here you can see the attachment of the capsule, the head of the radius, and this is the coronoid process of the ulna. The posterior aspect of the elbow joint, the olecranon, the subcutaneous part where you will get the subcutaneous olecranon bursa.
And actually the liquid is coming out of the joint.
Now this the forceps is the capsule. This is the capsule. And this is the synovial. Yeah, this is the lining, glistening appearance. It gives a glistening appearance. From that you can make out that this is the synovial joint. So you can see the upper edge that the capsule is attached to the upper edge of these fossa. Okay, you can see that. These are the fossas, the depressions. So this is again the olecranon fossa. The edges are lined by the capsule.
So anterior and posterior capsule are both visible, and now he is trying to show the collateral ligament and the annular ligament, which is also visible.
So this is the
medial collateral, the annular, and then how it is blending with the neck midway down, above the tuberosity, the annular ligament.
that ligament is the ulnar collateral ligament, this one, from the medial epicondyle to the lateral margin of the coronoid process.
Ma'am,
Mm-hmm.
is that extrasynovial fat shown here?
Where did you see?
No,
it
I
will.
didn't see. Is it there visible?
No. Actually, it is not visible anywhere. Actually, I should have played this video first. Here you can see the whole limb. The whole limb is present. The biceps, the brachioradialis. This is the area of the joint. The two heads of the biceps, you can see, making a single belly, a tendon of the biceps, the artery, so you can see the division of the artery. Here you cannot make out na. 1 minute. So where is the division of the brachial artery, at what level?
Below the cubital fossa.
Yeah, in the cubital fossa
Neck
and
of radius.
neck of the radius. This is the nerve. So you should be able to identify how a nerve looks like and what an artery looks like. Okay, I'm just stopping the video now. There is some sparking going on. Just call that attention. हेलो, हाँ मनमोहन जी, यहाँ पे ना कुछ स्पार्किंग हो रहा है, आप आ जाएंगे एलटी में एक बार?
Where is the sparking, Dr. Monica?
Ma'am, here in the plugs.
Oh, I see. The extension board.
Yeah, extension
So
cord.
yes. Put your mic on mute for 2-3 minutes till he fixes the problem.
Yeah, ma'am.
And then resume.
Ma'am?